Hi, everyone. We're about to get started. We're strictly doing this 30 minutes because the doctors have to get to another meeting. One question, one follow-up. Turn it over to the doctors for brief remarks.
Yes, well, good afternoon. And it's after an extra long weekend. And we're hoping that seemed to be everybody did the continuing physical distancing, social distancing, and did virtual faith gatherings, virtual family gatherings, virtual events. So I think I plotted all the different ones I saw, and I did take part in virtual gatherings. So that was a different reality and how to make it work. And I thought it went very well. And so today we're both back together again to do the information material. And as always, after a weekend, the data gets a bit of a flow thing with tests coming in. And after a long weekend, it's even more complicated with more times and delays and different aspects coming through there. So we're going to look at our data and our data points today and see where we stand. And then I'll have a few comments to make after Dr. Yaffe does the numbers. So over to Dr. Yaffe and the data for today.
Okay, thank you. So the numbers as of 4 p.m. yesterday, as entered by the public health units, there are a total of 7,953 confirmed cases of COVID-19 in Ontario, reported at that point. This represents an increase of 483 cases from the previous report, and the percentage of women is going up. It's 55.2%. 40% of the cases are 60 years of age and older. That is increasing as well. And almost 55% of the cases reside in the Greater Toronto Area. At this point, we've had, unfortunately, a total of 334 deaths reported, which is an increase of 43 deaths from the previous report. And we're aware of at least 93 outbreaks having been reported in long-term care homes, involving 136 deaths, some of which were lab confirmed, some are epidemiologically linked. We continue to see the number of resolved cases increase. We're now at 45% of cases, or 3,568 cases resolved. The number of healthcare workers who have tested positive to this point, cumulatively, is 857, or 11% of cases. This is not the number that is currently positive. It's the cumulative number since the beginning. We have currently 769 patients with COVID-19 hospitalized, which is an increase of 9 from the day before. 255 of them are in ICU. The number in ICU has gone down by 8. And of those in ICU, 199 are on a ventilator. That number has gone down by 4. In terms of the lab testing, we have now tested almost 113,100 people in Ontario. At this point, 2,107 are still under investigation. In the last 24 hours, close to 6,500 tests have been processed. I'll turn it back to Dr. Williams. Thank you.
Okay, well, thank you. And looking at the data, as I was saying before, we're trying to assess if we're totally out of any impacts of the travel. And right now, our overall percentage, that has dropped down considerably. So I would have to say very few have to do with the travel related. We're getting more and more reports of case contacts and more, unfortunately, of some events in the previous 2 to 3 weeks where people had decided to get together with others and thought it was okay to have communal gatherings, and some have reported then that a case was involved in it, unbeknownst to them, and they in themselves have become positive. So I think that that kind of laxity in that side has shown itself with some more cases being identified at this time here, and we're still at 483. The good aspect is that, unlike the predicted model where we would be doubling our number of cases every on a bad case every 4 to 5 days, on a reasonable model every 7 to 8 days, we're not even doubling on 7, 8, or 9, 10 days. We're plateauing at our numbers in the mid 400s. The 483, we have the weekend effect to try and build that in and cover that as well. So instead of the numbers dropping off precipitously, the good news is that they are plateauing. As I said, we're hoping to get a report back from our modelers on how we're doing. The other aspect that's of a point, as Dr. Yaffe has alluded to, is that our emergency department visits related to COVID have dropped off somewhat significantly, as well as our number of ICU admissions is down a little bit. So again, I would say the number of movements around the ICU admissions and that up or down by about 4 or 5 or 6, I don't think is significant. It means the good news is that it seems to be plateauing, and where they were supposed to be going up fairly precipitously if we had a worst case scenario, up considerably for a moderate and went up mildly for a good scenario. So we're interested to see how that compares. The other thing that's interesting, when we sat down with our federal, provincial, territorial members, we looked at the Canadian data from the Chief Public Health Officer of Canada, and they were noting that there's a number of evidences across the country that a number of the provinces, including ours, looked like they were plateauing, if you may use that term, in that regard. And the other thing that's interesting is that while we do tests, and no one does population-wide testing. If you do a test a certain number and you expand the criteria like we're doing here, you may get more tests because the positivity rate of those tests actually has more indication of how it's going than the quantity of the tests. Now, that may seem like an interesting statistic, and that's what the federal government looks at. And same we do with our flu season every year, where we start off at a low percent, it goes up to a maximum, then comes back down again. So same as our one in Canada peaked at around 12%, 13% positivity around the 4th of April, and was already coming down to 10 and under 10. So in Ontario, we're at about that 10% rate anyways. And I'll be interested to see if our percent positivity decreases, even if our number of tests we do goes up and we get some more cases reported by a statistical prediction. So I think those overall seem well. The main focus is what we're trying to address here, and as the Premier had spoken about on the press conference, is dealing with the long-term care facilities. Then after that, the retirement homes and other group and residential type settings in the province, as well as other high-risk settings. And we have been working at a strategy to increase the testing in that regard. And we are laying out a program in that we hope to have present to our cabinet later today, and then they'll have some more announcements tomorrow with details of that, of how we're going to assist in that regard, looking at using resources within the province, the long-term care facilities, the wide variety of facilities, what they have and don't have, adding resources from public health units to assist in that regard, expertise from Public Health Ontario, expertise from Ontario Health, and resources when needed from the acute care sector to assist on certain issues as we lay them out in our program. We'll have more details tomorrow that could handle that, because if the hospital vacancy remains at its low right now and the ED visits are down and we don't have a massive peak coming up, we could use such resources and expertise to assist in our long-term care sector accordingly. So we're looking at all sorts of aspects there in that. It's interesting, as Dr. Yaffe had noted, that our deaths related to long-term care homes is 136, which is less than 50% of our total deaths in the province. Whereas on the national basis, as the Chief Public Health Officer reported on the weekend, it makes up 50% of all the deaths in the province, in the country, is related to long-term care. So there's that aspect. The other one is, it's intriguing, as Dr. Yaffe alluded to, is that our cases have gone up. So there's a 10% difference between females and males, and yet on the national level, the deaths are more predominantly males than females. So it shows you we have some variations within the province and across the country therein. So with those aspects there, I'm going to ask our people to open up for questions.
Okay, we'll take questions from the first caller.
Your first question comes from Morgan Campbell with Global News. Please go ahead.
Hi, doctors. Thanks for taking my question today. I wanted to gauge your reaction on something here. Global News has obtained documents from Toronto Public Health and a directive from you, Dr. Williams, that states staff in long-term care homes that test positive for COVID-19 may return to work if they are asymptomatic or not showing symptoms of the virus, as long as they're isolated and wearing PPE. Why are we allowing workers who may still be able to pass the virus into facilities, to go to work and work in these long-term care homes?
I was asked about that. I did look at the directive, and the guideline is that a healthcare worker who, we had the ones before that had the travel history and some exposure, were asked to go to the 14-day isolation. There was a sense of the essential worker that could, if it was really critical and agreed on by all parties, could return to the work situation if they were still asymptomatic and wear proper PPE while on the job. The one you're referring to is that if you have a person or staff member who's asymptomatic, who, by the way, gets tested positive, it says that after 14 days after the test, they could return to work. So I think there's some interpretation issues there with what's being done at the local level.
So who would be deemed critical, and under what conditions would they work? Would they only work with other patients who are positive with COVID-19?
So the original position was to mostly deal with acute care hospitals, where they would sit down with all parties, usually with both management and union, and determine ahead of time certain key positions, for example, ICU staff, where they felt if there was people off because of the isolation period, the 14 days, or travel history, that they would be compromised in their programs and services. So they would agree on the positions that would be identified as essential, and those, if there was need be, could bring someone back before their 14 days was up if they're wearing proper PPE and monitored on a daily basis by the organization.
Next question.
Your next question comes from Rob Ferguson with the Toronto Star. Please go ahead.
Hello, doctors. Welcome back, Dr. Williams. I was just wondering, yesterday I was asking about the policy of still allowing healthcare workers to work in more than one nursing home. I'm assuming you recommended the change. I'm wondering what was the turning point for this decision, and if you wish you'd maybe done this sooner.
Well, from the beginning, we knew this was a concern, and we asked that there would be a number of steps taken in there that would, one, identify first who those workers are that work at multiple sites. Second, asking those employees who did that they would notify their employer, so the employer knew that they worked at site A, B, and C, for example, and if there was an outbreak in one, that they would not be allowed to work in the other two. There was a sense that saying, could you actually do something to reduce those number of multiple site working things? And we have been putting that to the recommending up for that to be considered. And various parts, including the Ministry of Long-Term Care and the Ministry of Labor in Ontario, have been working on how to do that. And I think in the press conference today, the Premier had made some comment that would be addressed. So we're waiting to hear back from the Premier on how they want to address that from that legal perspective.
Follow up?
I'm just wondering, you were talking about the extra resources in hospitals now that we haven't seen this surge. So what kind of hospital-based teams do you expect to be deployed in nursing homes? Can we get some detail around that?
So mostly what we're looking at is that in these, as you know, the hospitals have their own infection control committees, and they have their own infection prevention control practitioners, as well as other ones that look after their outbreaks. So they have a large skill base of trained infection prevention practitioners who can undertake on a regular basis the training of the staff within the hospital, the monitoring of the knowledge of the staff, the various protocols and procedures being adhered to and followed. So they've been doing that, ramping that up quite aggressively over the last number of weeks, preparing for how bad it could or get in the future and there. As such, since they have done some of that already, if we have a need out in the long-term care facilities because our public health staff are stretched. If you need to have more expertise to go out and help in training, education, and assessing of things around personal protective equipment, proper protocols around infection prevention control, and outbreak management accordingly, then we certainly would like to utilize that resource because they have the expertise since they have been able and have been running it within their institutions over the last number of months. They do it all the time, but even more the last couple of months in regards to COVID-19. So we're hoping to utilize some of that expertise to help us to do any gap analysis and fulfill that as far as a knowledge-based, practice-based, and I would say assessment and solution finding to work very fast at the long-term care issues, especially those in outbreak if and when they occur.
Next question.
Your next question comes from Phil Perkins with CH News. Please go ahead.
Hello there. As Dr. Yaffe mentioned, the amount of people in ICU beds and ventilators is down. Do we know why? Is that because they're getting better, or is it because they are no longer with us?
I don't have the actual breakdown of, the number that went in, the number that left, and how they left, but I think there are less people ending up in hospital, and some people are final and recovering, which is good news. Unfortunately, people with COVID-19 do tend to stay, when they're in a ventilator, they stay longer than others, but they do come off. But I don't have the breakdown for that question.
Follow up.
And when are we expecting the extra hands from hospitals to be implemented and working full time at the long-term care facilities?
So the question is that you said working full time at long-term care facilities. We were mostly wanting to use them as soon as we can, especially if we go through our assessment, identify that there is needs in various long-term care facilities, because there's quite a wide variety of long-term care facilities. Some are quite well resourced and can handle most of that on their own, some with a little bit of assistance from the local public health unit, but others may need more assertive action. So we're doing an assessment of what we need to prepare them better. Now we have adequate personal protective equipment for those facilities, and then to ensure that the staff are ready and prepared, as well as the organization, to deal with a potential outbreak, to deal with a presumed outbreak and a confirmed outbreak, and then even more further, if there's somewhere large outbreaks in institutions, how we might use that expertise, if you may, I wouldn't say it's not meant to be a full-time work level. It's supposed to be more on a task basis, that they would give us their expertise and time accordingly to assist as needed. And we'd identify, along with our Ontario Health regional offices, how best to do that. So it'd be like a partnership, if you may, with the institution, local public health, Ontario Health Regional, as well as the facilities in that area, as well as expertise centrally, as much as we need to ramp up accordingly to give all the advice they need to deal with an issue efficiently, effectively, and as quickly as possible.
Okay, next question. I believe that's the last one.
Your final question comes from Michelle McCoogie with the Canadian Press. Please go ahead.
Thanks very much. Dr. Williams, my first question has a bit to do with details that I know you're still working out to some degree. You outlined some of it today in terms of the care that can be, or the help that can be expected to be sent to the long-term care facilities. Do you have any kind of timeline as to when some of that additional help may be deployed?
Well, we're trying to work as quickly as we can to undertake that, because remember, last week we were saying that we were optimistic that the curve was bending and that the predicted massive increase in load to our acute care sector may not be as necessary. So we wanted to see how the data came out over the weekend and ask our modelers questions on that, so that could we avail ourselves of that resource. We couldn't before, if there was actually an impending huge caseload coming down the way for our acute care hospitals in that sense. So we've had that made available. And so we're trying to move as quickly as we can with also our increased testing capacity, the increased availability of personal protective equipment. And now this resource gives us 3 resources that weren't that readily available for us a week or so ago that we have now. And so we're very encouraged with that and trying to work as quickly as we can to utilize that to keep our number of outbreaks down, both in the frequency of the outbreaks, the large or size of the outbreaks, And as we're seeking to do to make where we can, where it's reasonable, of course, with these large numbers of frail elderly patients who are in their final stages of life in general, to make it to try and decrease any morbidity and mortality related to COVID-19 as much as possible.
Okay, follow up, and this is the last question.
Sort of building on the last point you made there, Dr. Williams, with regard to elderly patients, and this is more of a retrospective sort of question, but the ways that the COVID outbreak has played out in those long-term care facilities, do you feel that it's shown a bit of a light on how we as a society have handled their care? Do you feel that we've done all that we can to date in order to protect that vulnerable population?
Well, that's a question we always ask ourselves, and that's why we're doing this review and looking at it, and that across the country at the federal provincial territorial level, all the provinces are dealing with the same issue. And we're asking ourselves of how COVID-19 expresses itself, how it moves through in there, the whole aspect of having a number of residents in these facilities who have already have shortness of breath, already have some coughing, and do not have much of a fever. So it's very hard to pick these up very early because they don't evidence all the clear-cut symptoms of influenza-like illness, if you may. And at the same time, some of the staff are coming in presumably with either mild or presumptive or pre-symptomatic, and may be having some infection. So we're learning a lot as we go through this one and seeing how it evolves and looking at these high priority settings and how does it evidence itself in each one. So ask ourselves, can we do more? Well, that's why we're attempting to move in even more to see if we can even bend the curve in the long-term care outbreak situation, which is different as we see at the federal, provincial, territorial level. It's different than the general population. It's a unique gathering of high-risk individuals, and how do we best handle that with their levels of comorbidity and their limited immunity anyways. So we're all being tested at this across the country, and we're seeking to try whatever we can and to advise each other of our successes and some of the limitations therein, but everybody's putting a full court press on this matter.
Okay, thank you, everyone.